Ladies and gentlemen, welcome to Clinical Journal Club in English. It's 4 o'clock, and so we'll get started. The image in the New England Journal is shown here. It's a magnetic resonance image of a 68-year-old woman who has neck swelling, and she has some discomfort when swallowing. And what we can see here is that the lesion is anterior rather than posterior, and we can't tell exactly whether or not it's in the midline. Here's her tongue, and then we see this structure. And offered are pharyngeal abscesses that are almost always posterior or retropharyngeal, a tyroglossal duct cyst, reactive viral lymphadenopathy, I don't think this is a lymph node, Hodgkin's lymphoma, ibid to that, or a vascular tumor, a hemangioma. And the only possibility of the things that are offered here is a tyroglossal duct cyst, which can actually show up at practically any age, although in 68-year-old people, I suppose this is somewhat unusual. So this is the most common congenital cyst of the neck, and they can be removed, and then the symptoms are better. So this would be an example of a retropharyngeal abscess. It's in the back rather than the front. And these are obviously dangerous and have inflammatory signs, and usually diagnose these things by carefully putting your finger in the people's mouths and palpating these things. Here's a tyroglossal duct cyst. This is a young woman. This is a midline structure underneath the tongue, between the tongue and the thyroid gland in essence. And ultrasound is the quickest way to make the diagnosis. Although with CT, we can see this outpouching here consistent with the diagnosis that we saw the magnetic resonance imaging. Now, the first paper in the New England Journal is about breast cancer, and because the paper is about the 21 gene assay. This is a chip assay that looks at the expression of 21 genes. It's marketed by a company, Oncotype DX breast cancer test, and the paper that we're going to look at is about this, basically about this test. This is a 21 gene assay, and a year ago we looked at a paper from the same group indicating that scores that are derived from this assay can be of predictive value in terms of breast cancer, not as extensively as we might have hoped, but it might possibly select those women that do not necessarily have to have chemotherapy after the diagnosis of breast cancer is established. And we're talking here about hormone-receptor positive breast cancer and HER2 negative breast cancer. Indeed, this is the most common type of breast cancer that's diagnosed. And we're also talking about women that don't have a positive sentinel node. In other words, axillary lymph nodes have been obtained, and these women do not have axillary node metastases. Now, the first thing that we have to do is think about where this test came from, and the paper and the supplement to the paper don't give us that information. But basically, and this is back over 10 years ago, this test was derived from 250 candidate genes, the expression of which was examined in a whole series of breast cancers. And from these 250 candidate genes, 21 genes were selected that seemed to have possible predictive value. And these genes are listed here. You'll recognize some of them, and perhaps others you won't recognize, doesn't matter, but at least these are the 21 genes that are tested on this assay chip. And then on the basis of the result of this expression, these women are given a score on this test. And basically what we can see here is that the scores are divided into low recurrence incidence, high recurrence incidence, and intermediate recurrence incidence. And as I recall, if the score is greater than 25, the women were classified as having a relatively high risk of recurrent breast cancer, and also risk for the development of distant metastases. But if the score is less than 25, then this risk is intermediate or even low in some women. And in the first paper that we looked at a year ago, basically that was all that was inspected. This is basically a rehash of the first paper with one addition here, which I think was interesting. They decided to also include clinical information on these patients. I'm not talking merely about age and whether or not the women are premenopausal or postmenopausal. All these women got tamoxifen or other hormonal therapies such as an aromatase inhibitor. I'm talking about tumor size and the aggressiveness of the tumor as inspected by a pathologist. So these are the two additional clinical variables that are included in this evaluation of the same study that we looked at a year ago. And this is a little difficult to follow, but if we look at these plots here, we can look at greater event rate with higher clinical risk. Those would be women that had tumors that were greater than 3 centimeters in diameter, or tumors that looked aggressive histologically, or a low clinical risk, as opposed to whether or not they had a low recurrence score, that means 0 to 10, high recurrence score, that's 26 to 100, or intermediate recurrence score, which would be 11 to 25. And the cutoff for high risk is a score greater than 25. And I think it comes as to no surprise to any clinician that indeed clinical parameters do have an impact on outcome. And so the fact that tumor size and the aggressiveness of the tumor on the histological examination would have a bearing on this, I think is not surprising. And in terms of looking at the risk of distant metastases, that was also the case. And if we look at various subgroup analyses of whether or not chemotherapy was a benefit or not in these women that were prospectively studied over a period of years, we can see that age seems to have a bearing on whether or not the women had a benefit from a combined endocrine and chemotherapeutic regimen, and that seemed to be the case in younger women, irrespective of whether they had low clinical risk or high clinical risk. And if we look at a subgroup analysis, again, chemoendocrine therapy compared to endocrine therapy alone, we can look at the subdivisions of the scores in terms of those parameters. And if we look at the effect of age on and whether or not the women are premenopausal or both or postmenopausal, we see an effect of age and menopausal status on chemotherapeutic benefit as shown in this analysis. So again, in this table that shows these hazards and risk scores, we can see the breakdown in terms of the gene tests 0 through 10 or 11 through 25 or greater than 26. In terms of whether or not chemotherapy was provided an additional benefit. No chemotherapy compared to chemotherapy did not seem to be the case in the women with the intermediate recurrence score. That's what we also learned in the first study. And if the score was higher than 26, there seemed to be a benefit from having received the chemotherapy. So basically, this study showed that the recurrence score based on the 21 gene breast cancer assay provides fairly robust prognostic information and can help predict whether or not chemotherapy is going to be an additional benefit for the patient. And also, clinicopathological features provide prognostic information that's complementary to that of the assay. Now, as a clinician, I would have probably turned the study around to see whether or not the gene test improves the estimates based on clinicopathological features, but that's not what the investigators did. So basically, this paper corresponds to the paper that we inspected earlier in terms of indicating some women that could be possibly spared chemotherapy. And yes, indeed, including clinical pathological features seems to increase the robustness of the clinical decisions that are made. And there's a lengthy editorial about this whole issue. And the editorialist comments, readers may be surprised to learn that the classic prognostic markers were not directly analyzed in the 2018 article. And he also makes the snide remark that perhaps it's the issue of the authors to publish 2 papers rather than only 1. And details can be accrued hereby. You can read this editorial on your own. There's also a commentary in the New England Journal about gene tests and whether or not the genome has granted our wishes. And I think that this little discussion is worth reading, because if we look at the upper portion of this figure, results look fairly impressive. Risk analysis in terms of prognostic information of the gene test looks like a pretty good analysis. But if we look at the number of patients that fit with the orange line or with the red line down here, we're talking about 1% here and 1% here, which means that 98% of the patients lie between this range. That means that we have to do with basically a Gaussian or a skewed Gaussian distribution in terms of assessing risk. And if we look at questionnaire-based risk factor predictions, they don't look, in my view, that much worse than the gene test. So in the last 10 years, I would continue to be fairly skeptical about the idea that through gene testing, we're going to get magnificent insights. And the author here also points out that there are now at least 70,000 associations between certain single nucleotide polymorphisms and traits, but the influence of any individual SNP is so trivial that it becomes to be relatively meaningless. Now, the next topic at the New England Journal has to do with multiple sclerosis, and this is a severe encephalomyelitis that has an autoimmune basis that results in destruction of white matter in the central nervous system. And it's a complex issue here. This autoimmune disease involves B cells, T cells, and also myeloid cells, as are shown here. In this patient with multiple sclerosis, the stain here is for CD68, which is a marker on macrophages. And basically what was done in this study that I'm going to show you is an inhibitor against the Bruton tyrosine kinase was given. The Bruton tyrosine kinase plays a major role in B cells, but is also present in myeloid cells. And the Bruton tyrosine kinase sits here where BTK is located. So here we see the B cell receptor, and the signaling involves a number of different molecules, including the Bruton tyrosine kinase, phosphoinositol, 3-phosphate, and a whole variety of signaling events that have an influence on what cells subsequently do. The Bruton tyrosine kinase is what's mutated in patients that have X-linked immunodeficiency, and we've discussed that issue in the past. So in this fairly complicated MS study on MS patients with recurrent episodes of demyelination, these patients were randomized to placebo or several different doses of the Bruton tyrosine kinase inhibitor. And there's a 25 milligram group, a 75 milligram group, and this group got 75 milligrams twice a day. And another comparison group was treated with dimethyl fumarate, which is an acceptable treatment for multiple sclerosis to my knowledge. And the patients were inspected over a 24-week period, and then the study was continued for another 24 weeks. And the endpoint here is MRI examinations looking at white matter lesions. And so that was basically, this is a relapsing kind of multiple sclerosis. And so here are the patients. Most of the patients are women. Their mean age is about 40 years, and they've had relapses in the past, and various scores are used to estimate the severity of the disease, and their gadolinium-enhancing lesions on MRI was known, and the distribution of the 5 groups here is similar, so the randomization seemed to work. And what we can see here is that the endpoint, 25 milligrams of evobrutinib didn't seem to do very much, but 75 milligrams and 75 milligrams twice a day decreased the numbers of white matter lesions, which means that the episodes of relapse here was diminished, and that was also significantly different than the patients that were treated with dimethyl fumarate. And so if we look at unadjusted annualized relapse rates, these 2 doses of inhibiting the Bruton tyrosine kinase in these MS patients seem to be helpful. And we can see graphical displays of this, and the 75 milligram twice a day dose seemed to provide the greatest benefit for these patients. Were there adverse events? Yes, there were, and we'll look at these in a moment, but there weren't that many severe adverse events, but there are adverse events from inhibiting the Bruton tyrosine kinase. That included an increased amounts of grade 3 adverse events compared to the lower dose of evobrutinib or to placebo. So it looks like this additional therapy might have something to offer patients with relapsing multiple sclerosis. Now, the next issue in the New England Journal has to do with coronary flow reserve. And you may recall how this is done, but in order to determine whether or not a stenotic lesion is significant, we have a particular wire that can be used here that can measure the pressure gradient across a stenosed coronary artery. And the pressure gradient is measured under the condition of maximal dilatation, so that these patients are also given adenosine. And we know that patients that meet the criteria of having a fractional flow reserve benefit the most from having their stenotic lesions repaired, whereas those patients that don't have any fractional flow reserve don't seem to benefit from having their lesions stented or repaired. Now, this technique in this following study was compared to magnetic resonance perfusion. And again, in the New England Journal, there's no imaging shown, and so I had to go to a JACC paper to find out what was actually done here. And we can look at these scans where flow reserve is estimated by magnetic resonance imaging, which is also measured in the presence of adenosine, with an adenosine infusion. So what was done in this complicated study was that patients were randomized to either fractional flow reserve determinations by means of the wire across their lesion or a magnetic resonance imaging study. And these patients were then revascularized in terms of what the findings were, and then hard endpoints were looked at in terms of a primary outcome that included death, non-fatal myocardial infarction, or target vessel revascularization at 1 year. This is a fairly complicated study, but these are patients basically with stable angina that had a Canadian Cardiological Society score of around 2, and there were some heart failure patients, but the heart failure was not the issue here. Otherwise, the randomization seemed to work. I was interested to learn that they had to examine 16,000 patients to find 918 that were eligible for this complicated study. And basically what was done here is shown here. So fractional flow reserve was measured in one group with one technique and the other group with the other technique, and then they were treated accordingly. And what we look here is with the invasive measurement of fractional flow reserve, the number of stents that were placed, et cetera, was slightly higher than in the magnetic imaging group, but otherwise the results here look fairly similar. Death from any cause, more people in the cardiovascular imaging group died than in the direct flow reserve measurement, but the numbers here are trivial and no statistical significance can be accrued. And if we look at the result here, it looks like cardiovascular MRI group did as well as having direct measurement of your fractional flow reserve. So the imaging people think this is wonderful because their test is no worse than measuring fractional flow reserve directly. But I think that there are some issues here. You have to buy a 1.5 Tesla MRI scanner. You have to hire a whole team of people that take care of it. You have to be rich enough to buy a whole bunch of liquid helium to work the damn thing. And then since the cardiologists do all the tests that they have available in all the patients anyway, it's not clear to me how this is going to particularly help the patients, but the investigators saw that differently. The next topic at the New England Journal is hypertension. I love this topic because it receives relatively little attention. But as we see here from this breakdown in science that's based on the global disease burden studies, we can see that the contribution of hypertension to deaths worldwide is phenomenal, and at least almost twice as great as the risk that's provided by smoking, and almost twice as great as what's provided by glucose levels, type 2 diabetes, and more than twice as great as solid fat, and more than twice as great as liquid fat. And all these other issues here play a more trivial role. So if we all drove electric cars and ate only whole grains, there would be absolutely no difference in outcomes. So it would seem to me that addressing hypertension is worthwhile to do. Now, that was done in this next New England Journal study. And this study was done in Africa. And since most of the people there are black, this was done in black Africans. And they were randomized to various blood pressure lowering drugs that we know from previous randomized trials. And the primary endpoint was the change in 24-hour ambulatory systolic blood pressure comparing baseline to 6 months. At least they used the 24-hour ambulatory measurement as a hard endpoint, although office blood pressures were also measured. And the groups were randomized to receive amlodipine plus hydrochlorothiazide, amlodipine plus perindopril, and at least they used an ACE inhibitor that I'm convinced has at least 24-hour duration of action. And then the next group got hydrochlorothiazide and perindopril. Now, I don't know why the investigators didn't use chlorthalidone, which is the oldest hydrochlorothiazide-like diuretic, and also the drug on which we have the most information. And randomized trials of chlorthalidone compared to hydrochlorothiazide seem to indicate that chlorthalidone is better, but that's not what was done in this study. So the randomization worked, and blood pressure went down basically with all the treatments. I'm relieved at that. And if we look at the effects here, the table is going to go by a little fast, but you can perhaps appreciate that as we might have expected, the amlodipine plus hydrochlorothiazide group had greater effects in terms of lowering blood pressure, office blood pressure, and also 24-hour blood pressures than the other groups of treatment. And that can be seen here. So this is office systolic blood pressure, and in red here is amlodipine plus hydrochlorothiazide, which was a little better than amlodipine plus perindopril, and quite a bit better than perindopril plus hydrochlorothiazide. But I think we already knew from earlier clinical trials that Africans and people of African extraction seem to respond best to hydrochlorothiazide plus amlodipine compared to these other drugs. So I don't really think that there's any surprise here. And there were no problems with hypokalemia, if that's of concern to you, and the effects on pulse rates were also not dramatic. And the side effects were, as you might imagine, angioedema showed up with ACE inhibitors, and peripheral edema showed up more with amlodipine, etc. And thank goodness nobody in the study died. Then the authors state that the results are contrary to guidelines. Guidelines are opinion pieces by experts, but I think the US guidelines and the European guidelines both state a calcium channel blocker or a diuretic in combination seems to be a particular benefit in Black Africans, so I didn't think that these results were particularly surprising. Here's a patient in the New England Journal. This is a 17-year-old boy who presents to the emergency department after his e-cigarette exploded during use. And what I think is remarkable is what we can do with imaging. This here is a CT, and I think it's wonderful what you can see here. And you can see he's going to lose a couple of teeth here and a bone chip, etc., and that's shown here. But it also indicates some problems with e-cigarettes, although I think in terms of environmental pollution, they seem to have a substantial benefit over what what people generally smoke. Here's the patient from last week with the morantic endocarditis, and we can see these splinter hemorrhages in both fingers, and we can also see infarcts in liver and spleen and kidneys. And this patient did not have bacterial endocarditis. He had morantic endocarditis from his pancreatic cancer and subsequently died. Now, the review in the New England Journal is quite timely if you live in Europe, and it has to do with heat stroke. Heat stroke are increases in body temperature greater than 40 degrees centigrade on the basis of the patients not being able to dissipate heat and being unable to regulate body temperature appropriately. And there are two kinds of heat stroke that are discussed here. A classic heat stroke that we see in sedentary elderly patients primarily, and exertional heat stroke that we see in athletes and soldiers, etc., who have to perform substantial physical exertion outside when it's 40 degrees ambient temperature. And these patients can be separated on clinical grounds, generally fairly easily on the basis of history and also physical examination. And you can look whether or not the patients sweat, whether or not they have respiratory alkalosis as opposed to metabolic acidosis, and whether or not they have rhabdomyolysis, liver dysfunction, renal failure, etc. We can divide the patients into these two groups, and that's discussed here in great detail. The pathophysiology of these conditions is different. The risk factors are different, and particularly in old people, if they're taking 9 different medicines, including a bunch of psychotropic drugs, they have a much greater risk of getting heat stroke than if they don't take these. So the pathophysiology of these two conditions in these two patient populations are different, although as far as I can tell, their treatment's pretty much the same. And we have to lower their body temperature. And we have to make sure that their circulating fluid volume is adequate, so we need to put a central line in them, and etc. And here we have the opportunity to infuse cold solutions, which could be a benefit, but otherwise we have to bring their body temperature down, and cold water immersion seems to be the most effective means to do that. These problems can be prevented, and the prevention of these conditions are generally fairly obvious, but at any rate, you can check these things out on your own. And there are genomic or genetic traits, although thank goodness gene tests have not yet been recommended to determine the risk of developing this condition. Now, the next review in the New England Journal is also timely because it's a little different. This author talks about non-narcotic methods of pain management, which I think is a little refreshing. And this is the first time that I've seen somebody in the New England Journal point out that this smiley face scale on the patient's own assessment of how much things hurt may not be appropriate. So this author even writes, a common way to assess pain is to ask the patient about the intensity of pain on an 11-point numerical scale. But overdependence on the assessment of pain with the use of these scales can lead to unnecessary opioid use. Amen to that. The author also points out that chronic pain, such as back pain or chronic aches and pains that people have that have no obvious substrate, don't benefit from opioid administration. And long-term opioid administration in these patients leads to a whole variety of problems of which we're by now well aware. And the options that we have involve addressing various targets that are shown in this nice figure here. So non-opioid analgesic agents are what should be used here if any drug is necessary, and I think that's an individual decision. Interestingly enough, the best clinical information involves an antidepressant. And I'm not talking about the flashy new things. I'm talking about a drug that's been around for 40 years, and that drug is amitriptyline. And there's more information about amitriptyline, not just in depressed patients, in chronic pain patients without depression, that amitriptyline has efficacy, and that's discussed here. Acetaminophen is kind of plus minus. Aspirin has been around for more than a century, non-steroidal anti-inflammatory drugs, etc. And then the limited administration of gabapentin for patients with neuropathic pain, or pregabalin, IBID, or rubbing lidocaine or capsaicin on these lesions can also be helpful, and these issues are discussed here. So this is a pretty good article that introduces a new avenue so that physicians can get out of this trap of prescribing opioids for pain syndromes, including post-operative pain, which in my opinion is overdrawn. So here are some strategies for you regarding to that. Now this next patient in the New England Journal, I kind of went down the tubes on this one, I also have to confess. This involves a 38-year-old woman with abdominal pain and fever, and it looks like she has Crohn's disease, and a whole bunch of laboratory tests are done here that are actually consistent with that, and her imaging studies are also consistent with that. But her Crohn's disease with the various drugs, and she gets the usual stuff for Crohn's disease, doesn't get any better. And so finally she receives some anti-TNF therapies, and then things even get worse. Now she has an interferon gamma release assay, because if these people get infliximab, we always have to think about the possibility that they might develop a complication such as the activation of tuberculosis. But an interferon gamma release assay was negative. And I learned to my surprise that these assays are not very good in patients that are immunosuppressed, particularly if they're getting TNF inhibitors or prednisone. Then we learned that this woman had immigrated to the United States from India 13 years before presentation. That means that her risk of having been exposed to tuberculosis is probably 100%. So here are the imaging studies which the investigators taking care of this patient interpreted as being Crohn's disease, but discriminating Crohn's disease from tuberculosis is not trivial. Then they ask her if she has pain, and of course she rates herself as being a 9. What else is there? And some other imaging tests are done that show involvement of the small bowel, but not really with backwash ileitis, and there's a lot of colonic change here, which are somewhat atypical for Crohn's disease, but then her fecal calprotectin level was 1372. And then these possibilities are discussed. And the discussant is really pretty good and indicates that the interferon gamma release assay for tuberculosis can be negative in these patients, so we can't rely on that. So this patient then underwent an operation. And the right side of her colon, where most of the activity was involved, was removed, and we see granuloma formation, which is suggestive, but Crohn's disease is also a granulomatous disease. But then other studies were done. She had a normal chest x-ray, but this CT shows some apical lesions here that are pretty darn suspicious, and some lymph nodes that were enlarged. So with mediastinoscopy, these lymph nodes were excised and examined with PCR, and then even culture, and the diagnosis of tuberculosis was established in this patient. So we have to keep that possibility in mind and put it way up front in patients that have lived in areas where tuberculosis is endemic, such as India. Then I was interested in this question here in the New England Journal that I have to admit, this irritated me a lot. So the issue concerns a 54-year-old man with obesity, hypertension, and no history of cigarette smoking. That's nice. He gets short of breath going up 2 flights of stairs. Okay. Oxygen saturation is measured, and he has a saturation of 93%, which we should know immediately indicates that his PO2 is about 65. Then some lab tests are done, and he has a serum bicarbonate of 34, which in US laboratory testing is routinely measured. That would not be the case in Europe, unfortunately. And then we see what else happens. So this patient then gets an echocardiogram, which gave a positive result, but I didn't quite understand why this was done. But this patient has pulmonary hypertension, which is understandable. And then he's sent to a sleep study, and of course he has sleep apnea. Okay, that's basically sort of a no-brainer, but I don't think I would send a patient for a test that costs several thousand euros without at least measuring his arterial blood gases and doing spirometry, which is an office procedure, before I schedule him for a sleep apnea test. But then we're asked what should be done next. And one of the things that's offered here is arterial blood gas testing, but we know that he's got a saturation of 93%, so his PO2 is 65, and his bicarbonate is 34, which means that he has a PCO2 of 70, and then we can calculate his hydrogen ion concentration from Henderson's equation, so he ought to have a pH of 7.30. So that's the correct answer, arterial blood gas testing, but I think I would have measured arterial blood gases before I would send this person for a sleep laboratory test. So much for that. Now we move to the Lancet. And the Lancet is concerned about alcohol intake and draw attention to the fact that alcohol intake between 1990 and 2017 has increased worldwide from 5.9 liters to 6.5 liters. Bad. And the authors do some mathematical modeling here to indicate that alcohol intake by 2030, I hope I make it to then, will be 7.6 liters per person per year. And then we can look at that and how these models that were done here and all these people that like to drink alcohol, which I guess seems to be spreading throughout the world, except in these countries where it's forbidden for various religious reasons, etc. But fear not, all the countries are represented here. But I was interested in the fact that the Europeans, their alcohol consumption is actually falling. So over here, we're pretty good. And the ladies are wonderful anyway. They hardly drink at all. It's the men that are the problem. But even European men are projected to decrease their alcohol intake. So we're safe, as opposed to the Africans and the Far Easterners who I assume are drinking more alcohol, as this analysis seems to indicate. So that means that alcohol use is increasing in Southeast Asia and the Western Pacific regions and even in India, but it seems to be decreasing in Europe. Good. The next review in the Lancet I think is important because it's a huge meta-analysis on whether or not drug-eluting stents or bare metal stents are better. And so this is an analysis that involves 20,000 patients that were randomized to one or the other. So if we look at the table here, randomizations worked, and the people have multivessel disease, and There's some differences, and we're comparing here drug-eluting stents to bare metal stents, and why the total stent length would be longer with the drug-eluting stents compared to the bare metal stents is not clear to me, but the difference here is clinically trivial. Then we learn that the drug-eluting stents are better. But if we look at this graph, I think these people mislabeled this graph here, because here it looks like the drug-eluting stents are actually worse, and that's why I put a question mark on this figure. I think something's wrong here. But at any rate, the message here is that drug-eluting stents on the whole are better than bare metal stents, and with all the money and effort that's gone into developing these, I would certainly hope so. And this breakdown is shown here. So if you insist on giving me a stent, I guess I'd rather have a drug-eluting stent than a bare metal stent. The next study involves the treatment of gonorrhea. And when I was a junior physician, this was fairly trivial. We just gave everybody penicillin and it went away. But that was 50 years ago. Life has gotten worse. So gonorrhea is difficult to eradicate, as I learned. And in this study, the patients were randomized to gentamicin against ceftriaxone. And the idea here was that gentamicin would be no worse than ceftriaxone, although gentamicin is ototoxic and nephrotoxic, and ceftriaxone is not. And as a background, all of these patients also got a gram of oral azithromycin. So this is heavy-duty treatment. And as I saw to my chagrin and surprise here, the gonorrhea has also changed, because we're talking about genital gonorrhea, pharyngeal gonorrhea, rectal gonorrhea, and some of these patients had all three at the same time. And they were randomized to these treatments. But it looks like gentamicin was not as good as ceftriaxone, and that's basically the bottom line here. So these complicated patients with gonorrhea should receive ceftriaxone instead of gentamicin. And these are the MICs. I know what MICs are here, and I know what drug clearance is, but what MIC clearance is, I couldn't figure out what that was. But at any rate, the values are given here. So the bottom line of this study is that ceftriaxone should remain the treatment of choice, first-line therapy for complicated gonorrhea. And gentamicin can be held in reserve. Then last week in The Lancet, we inspected 2 papers on gender equality. Well, the ladies weren't satisfied with that, so now we have 3 more papers on gender equality. And most of the authors are female. The first paper has to do with improving health with programmatic, legal, and policy approaches to reduce gender inequality. And here are the key messages. High-quality gender transformative programs. Tuition-free, everything needs to be free nowadays. Tuition-free primary education. More broad policies and programs. Increased gender equality and governance for both policy and programmatic intervention. And then this is all shown in multiple tables in this paper, and how things are changed, how things are expressed worldwide, where tuition-free education, that's fairly limited. And they list the United States as having this is quite accurate. No tuition-free education and no paid leave. The Americans should be ashamed of themselves, because they don't do any better than the South Africans, and even Somalia is no better, no worse. So the next paper is on more gender equality, disrupting gender norms in health systems. And since most of the health care is provided by females nowadays, this is important. And gender and social equalities, health systems can be disrupted, gender transformative approaches, I'm not quite sure what they mean by that, but it's outlined here. And the share of the workload and wage gaps, they shouldn't exist. I agree with that. Matter of fact, I agree with everything in this paper. I agree with all these authors. But whether or not I agree is probably irrelevant. The next paper is also on gender equality and gender norms, framing the opportunities for health. And this material is reviewed here about gender biases in research healthcare systems. These authors are preaching to the choir. The choir in the church consists of individuals that have already been converted. So I think that these ladies should be directing their attention elsewhere. They need to be talking to these guys, and these are not Lancet readers. And they are the basis of the problem. And they need to be addressed by these authors. And this is a problem because these two people down here on the right, they're the only ones that aren't wearing fancy headgear. They probably left their baseball caps in the car. This person on the right is the Most Reverend Jerry Falwell Jr., who's a popular U.S. television preacher, and his main ally is shown here on his left. But at any rate, the issue, as we see here in the New England Journal, is that the rights of women, at least in the United States, are being impinged upon because it looks like the Republicans are going to move hard to repeal Roe versus Wade, which was the Supreme Court decision that was made, I believe, in 1972, that provided some choice for women. And all the states here that are shown here in red are the ones that are either very hostile and very red, or hostile towards termination of pregnancy under any circumstances. And these people call themselves pro-life, but they're only pro-life up until delivery of the placenta, because after they've seen the afterbirth, all they care about is the afterlife. And in terms of providing health care or public schools or education or opportunity for all, they're not interested in those things at all. Then from science, we have a twin study. Since I founded a twin cohort here in Berlin and I'm interested in genetics, I was interested in this paper. But this is an N of 1, and I do mean 1 because monozygotic twins are supposed to have the same genome. So they share their genome. And one of these twins was shot into space and spent a year up there, and the other twin was not. If I would have done this study, the reviewers would have said, N of 1, do 10 more. But these authors, I guess, were lucky. And what they did was all these wonderful things: cognition, biochemical, epigenomics, metabolomics, proteomics, genomics, telomere examinations. It's all wonderful. And basically what they found was that going up in space is bad for you, and your telomeres get shorter. And even after a year of 6 months after being back on Earth, some of these things had gotten better, but not all of them. I don't think I need to go up in space. Then we close with this poor woman. This is a 77-year-old woman that comes with these awful breast lesions. And this is Kaposi's sarcoma. And the stains here this is a viral-induced malignant tumor. And Kaposi's sarcoma is caused by herpes virus 8, and that's shown here. And we see this almost exclusively in patients that are HIV positive, although this woman was not HIV positive. This can probably be addressed with treatment. However, she was unfortunately lost to follow-up. That's it for this week.
Lost what?
Lost to follow-up. That's it for this week. You can stick around for 10 minutes and hear the same story in German. Otherwise, we'll see each other next week. Thank you for your attention.
Thanks very much.
Thanks a lot.